You're listening to a social justice podcast hosted by Nicola Spurling, brought to you by The Flag Shop, and inspired by a social justice coloring book. Hello and welcome to a social justice podcast. I'm Nicola Spurling, your host. Today I'm joined by Benjamin Perry and Joe Richards for a conversation on healthcare. Ben, can you tell us a little bit about yourself?
Yeah, my name's Benjamin Perry. I'm a speech therapist of about 15 years. I've mostly worked in a child development center, which is a sort of like a community health setting, interfacing with families and of children with disabilities. I'm also active with the healthcare union, advocating for healthcare workers and our healthcare system.
And Joe, would you like to tell us a bit about yourself?
Yes, I am a nurse with Providence Healthcare. I've been a nurse for 3 years. And I work primarily with, it's high acuity medicine at the hospital that I work at.
Great. Well, thank you both for joining me today. I'm looking forward to this discussion. My first question is, healthcare, normally we define the topics before we get into them, but I don't think healthcare needs defining. So I think what we want to do here is, it's a very broad topic, and we're probably going to end up sticking to discussing healthcare as it relates to Canada specifically, because I think that's what we're all probably the most knowledgeable about. And if possible, we'll touch on maybe what other countries do by contrast throughout this conversation. Mm-hmm. But when you think about healthcare, what is the first thing that comes to your mind?
What's the first thing I think of with healthcare? It'd be wellness, illness and wellness, but the goal to be wellness. Whether it be physically or mentally or emotionally.
So just kind of all around well-being.
Yeah.
Mm-hmm. Yeah. I mean, I think when I'm thinking about healthcare, I think usually everything's going really well. You know, I have my occasional, for me, health, like minor aches and pains, but like when I actually need health care, it's like a really vulnerable situation for me. And I need someone there that's going to be able to take care of me and not do any harm to me too.
Hopefully having people in healthcare that you can trust to do what's right for you.
Yeah.
And you know, almost all the time there's great people in our healthcare system that have helped me so much, and I've been fortunate to have mostly good experiences.
Mm-hmm. Well, yeah, I mean, I know as a trans person that is extremely important. I've been with someone who, when we went to the hospital, one of the nurses was just incredibly transphobic, and you know, that doesn't make you want to be in a hospital. It doesn't want to make you seek the care that you need. And I think it's very important that you have healthcare professionals that you can trust. So I try to make our conversations about each topic fairly general, but because we all live in British Columbia, I want to talk about some of the issues that relate to British Columbia specifically. So we have things like shortage of doctors, lack of dental coverage. What are some other issues that you can think of, and how could you see them potentially being resolved?
I definitely would say that, and this is actually a Canada-wide crisis, but the mental health crisis, specifically how it is being shown in the downtown east side. Just that there's many comments in the media about how every year that number rises. One of those reasons being that Vancouver is one of the most temperate places in Canada. So if you are living outside, or you're finding that you have no fixed address, or that you're finding it hard to find housing, that Vancouver is the mildest. Right. Down on the downtown east side, there's actually a lot of resources. But I think that in BC, we're seeing that sort of rise in like a mental health crisis and the fentanyl overdoses, and also just in what we're seeing in the hospitals and in people trying to access resources.
Well, just thinking about the healthcare system, critical shortages in every healthcare profession, nursing, all the health sciences, respiratory therapists, I think is a big one. Family doctors, general practitioners. And then when you talk about the poison drug crisis, there's shortages in every aspect of that, the treatment for that, the solutions for that. And I know this from talking to people in in this industry, there's that support, the mental health support that the longer term, 2-3 year support to help stabilize someone who's a drug user or addicted to drugs or having a mental health crisis. That's lacking, the longer term stuff.
Yeah, that's actually one that I wanted to touch on as well, the toxic drug supply. It seems like the government's willing to treat it as a legal issue and provide funding for approaching it from a legal framework, but it doesn't seem like there's that same desire to treat it from a healthcare standpoint. Do either of you have some insights into why that might be?
I think that it might be sort of an old school mentality. I'm going to kind of go off on a limb here, but it's like that example that you tell your parents, like I'm a millennial, I tell my parents that I'm in therapy and they think, what happened to you? But then I tell someone who's also a millennial that I'm in therapy and they go, oh, I'm in therapy too.
Right.
And it's sort of this generational thing where exploring mental health is sort of taboo for certain generations. And so when it comes to who designs our healthcare system, it's still sort of the older generations. It's moving more into millennial and Gen X, but it's still sort of structured around this idea that mental health is taboo and that if there's something wrong with you, we can fix it with a pill.
Right.
And that's really it. And there isn't really discussion in hospital as much about other ways of coping. And there's not very much discussion about exercise and food and living space and environment and things like that, just as a base. And then going into, I know that you want to talk about mental health later, but going into like counseling and different ways of coping.
Yeah, absolutely.
Yeah, I mean, in mental health, like often the issues are in young adulthood. People are dealing with issues of identity and leaving that sort of being a child, having an institution, having a school, having parents, and so many supports could be helpful at that time for that process.
Yeah, it's almost as though by pushing pills on people as opposed to therapy, you're contributing to that toxic drug supply. You're making people reliant on drugs as opposed to other forms of treatment. And if they can't access the healthy drugs through a hospital, then they're resorting to illicit drugs that might be poisoned for dealing with those mental health issues. And then we wind up in this never-ending spiral.
Yeah, an issue that we actually have is that when people develop chronic pain and other reasons for wanting to use drugs that alleviate pain, the hospitals can't match the amount that they can access on the street. So I've seen people from all walks of life go to the downtown east side or wherever to get these very strong doses of drugs because they're in so much pain and the hospitals can't meet that for them.
Right.
They can't prescribe that level of pain coverage for them, and so they have no choice.
Right. So this isn't sort of a historic problem, for instance, with oxycodone being prescribed.
It can also be that, but yeah.
Well, definitely it could also be that, but that's not necessarily the only issue at play. So there's all sorts of different angles that we have to approach this from when it comes to how to address the toxic drug supply from a healthcare standpoint.
And when you say like there's an interaction between, say, emotional pain, psychological pain, and physical pain, they all add to the same pain bucket.
Yeah, absolutely. Yeah, people use lots of things to self-soothe.
You would think when so many people are dying from these illicit drugs and when the root issue is often healthcare needs, whether it's pain, whether it's, I suppose mental health is also pain, right? But it seems counterintuitive to force people into getting it on the streets when you could instead provide a safe supply of those drugs. So why do you think there's such a pushback against providing safe supply to those individuals?
I've heard a few people who are opposed to it. And I think that there's a thinking that a safe supply will increase the use of illegal drugs. Well, there's no short supply of drugs. There's there's nonstop supply. So I think that's wrong. The idea of safe supply is that it won't kill people.
Mm-hmm.
But I mean, if we wanted a big bag of drugs right now, I bet we could go and find it.
Yeah.
Mm-hmm. I wonder too if that whole say no to drugs campaign had something to do with it as well, where there was almost this mentality that, well, you want to not do drugs, just don't do drugs.
Yeah. It was very
Simple.
idealistic, but it's the same. It's like a sibling to the abstinence campaigns that we experienced at our high school that we both went to,
Mm-hmm.
where that was their line. They said, you know what, the best way to prevent all these things is just not to do it. And it's like, you're not really teaching young people both sides.
Mm-hmm.
It's not really giving us insight to what life could be like. Kids are going to experiment. Kids are going to have sex. You can't really say, don't do it. And kids are going to be like, okay, because you said so.
Yeah, and I'm glad to see that that's shifted because you mentioned our school, but I think there was a shift between when you graduated and when I did.
Oh, really?
I had sex ed that did not teach that.
It was very,
interesting.
What's the years difference between us? I was 2005.
I was 2008. It's only a 3-year difference.
Only 3-year difference, yeah.
Yeah. But I think I came to the school in 2005, so maybe it was just sort of being phased out at that point.
But I also feel like they taught sex ed in the earlier years. This was grade 8, grade 9. Mm-hmm. They don't bother with the 12th graders.
Yeah.
We're pretty set in our ways.
I think ours was in grade 10 or grade 11.
Okay. Maybe they shifted it.
I just remember the wooden penis coming out.
And we didn't have that. It was in gym class just being told, just don't do it.
Was this in public school?
Yes, yeah.
Abstinence was taught, yeah.
I'm older. I graduated from high school in 94.
Mm-hmm. It's only 11 years.
Okay, but it seems like a long time.
Yeah.
Sex ed I had a great sex ed in 7th grade from my 7th grade teacher. Abstinence was not prominent. It was probably mentioned as one of the options. So I don't know what happened in those 11 years where they suddenly got onto.
I think it depends on jurisdiction as well. Like in grade 5, which would have been long before you probably received that abstinence education in high school, I had sex ed in elementary school where it was quite progressive from what I recall, minus the queer aspects.
Yeah. But those also were not touched on.
No.
But I feel like in elementary school it was very biological. It was just teaching us what was going to happen and not that it was something that we might want to do. Especially in the 5th grade, you think, ew.
I don't remember that there was ever, this is something that you're going to do. Yeah. There was definitely the ew factor, but there definitely was not a abstain from this message that was being pushed to us either.
Yeah. Mm-hmm. That might be lost on a bunch of 11-year-olds, maybe. But also, the town that we're from was very Baptist. So, and I think that a lot of the teachers had their own agenda, and they did push their own ideals. Because I had a teacher make a comment about queer people, primarily lesbians. And this was before I realized my own identity. I was sort of just floating, but I had grown up with 2 uncles who were gay and who had actually died during the AIDS epidemic. So I felt strongly about what she was saying, and we had a slight argument in class, but it was never brought to a principal. She was never brought to justice, in my opinion.
Right.
But she had this strong opinion.
Interesting.
About a band teacher that worked at our high school.
I took that band class.
Yes.
And I remember
exactly
that
who I'm talking about.
I know exactly who you're talking about. And she was very much gay, for sure. Yeah.
Yeah. Yeah. So it was an interesting, people they just expressed how they felt. I think that happens a lot everywhere. You want to remain politically correct, but you have an opportunity to talk to young minds about what you believe in, you might take that opportunity.
Yeah. I mean, I go and speak in schools because what I needed when I was a kid was inclusive sex education, education. We're getting a little bit off topic here, but that was something I really needed. So it's that mentality of be the change you want to see in the world. So, okay, I'll go talk in schools and be the trans person that kind of tells other people this pathway exists as an option for you.
Yeah. Well, if you want to bring it back to healthcare, when I was in nursing school, we took a course. It was a 1-day course, and it was on the whole rainbow. It was about everything. It was 1 2-hour class on gay, lesbian, queer, intersex, trans, two-spirited, asexual, everything, bisexual, pan, all the
I've even
alphabet.
taught healthcare students.
Yeah, and I had my instructor stand up and ask me, or ask the class, do you know what non-binary is? And I explained it, and she asked me to teach the class.
Amazing.
No, not amazing.
Oh.
She should have been equipped.
Oh, you mean because she didn't know?
She should have been equipped to teach that class.
Oh.
I shouldn't, because I'm not non-binary.
I thought it was a question, like
No.
she knew the answer. But
Maybe she did. But the way that I explained it to her, she felt confident that I could teach the rest of the class.
Interesting.
So I stood up and I went through the slides and I explained things to the best of my knowledge. But I explained that, I have one lived experience, and I, am like cisgendered. I identify as gay or lesbian or queer. My progression through my young life was challenging, but I grew up in Vancouver, which was quite liberal. And I was sort of at the end of when it was sort of a problem. And I kind of grew into this time now where it's a little bit easier for the L and the G and the Q in high schools. I can't speak on the other experiences.
I think it's easier across the board, but it's a little further behind for some others.
You know what I mean? And I was put in this position, and there was no plan to teach all these people in my course. They're all adults, about trans people, about anyone that it wasn't obvious. And they wanted me to teach this lesson. And I kind of said something. I was like, there's going to be trans people. There's going to be non-binary. There's going to be people with preferred names. There's going to be intersex. There's going to be lots of different people. And it's not a requirement in this program to learn about those people. And if you have your program in Vancouver, there's a very good chance that you're going to encounter these people. I encounter them all the time at the hospital that I work at. And I felt if it came to, social justice, that Canadian schools, specifically to BC's nursing schools and other schools should be teaching things accurately. In order, and I actually think that it's as important that you should be failed out of a nursing school if you can't grasp those concepts as much as you can't grasp the medical aspect. Because you could graduate a student and they could not grasp those concepts at all, and then they feed that into the healthcare system. I've seen it where people have been misgendered. We've had a few trans women who have not had bottom surgery, have chosen not to, and they have been treated very differently because of that.
There's actually a hearing happening right now with a nurse who has been taken to the BC Human Rights Tribunal, I believe it is, because she was unwilling to correctly gender patients and basically felt that she had the right as a nurse to state her opinion however she wanted, even though in doing that, it was negatively impacting her patients. So I don't know what the result of that's going to look like. But it's definitely an interesting conversation. And that idea of educating healthcare workers on social justice issues is exactly why I've taught healthcare students in the past, because instructors have said, well, I'm not knowledgeable on this topic, so let's bring a trans person in and talk to them about queer issues and make sure that they understand that. And I think that that's as much as you would want the teachers to be educated on it themselves, recognizing those limitations and going, I don't know everything I should know to give the students the best education they have. So let me bring in an expert so that they can get the education that they really need.
My union, my health union, provides that service to our sites.
Okay.
So there's an employee of the union who's a lawyer and is as an LGBTQ2A plus 2S plus identity, and did the education we invited all the staff. As a local union leader, I was trying to get everyone to come. We knew the people that didn't want to come and they didn't come. And was an hour with a whiteboard and lots of letters and lines and all kinds of stuff. It was really cool.
Amazing. So have you had that experience of having to learn about various different identities or, I guess, intersections between healthcare and social justice issues within your work?
Well, for clients, it has come up very rarely. I work with children mostly and families. So we have had some, I think either gay or lesbian parent couples. And from a union perspective, it's also about just sort of having to stand up for human rights, misgendering and things like that as well a few times. But I think because it's with kids, it's most often cisgender parents and children who are of unknown gender and sexuality.
Yeah, right. It's usually younger kids that do speech therapy.
Yeah.
Yeah, and it takes a lot of people a while to figure out if they're gay or trans or whatever it might be. So that would make sense that you haven't had to sort of encounter that quite as much. Shifting directions pretty radically at this point. I'm going to ask a very simple, possibly question. Is universal tax-funded healthcare better than privatized healthcare? So
I think that there's benefits to both. I do think that the government-funded healthcare is more. There's more equality in that. But I watched my grandpa when he was ill go to a Canadian doctor and be told there was nothing wrong with him. He was just falling over because there was fewer doctors in Canada. They were overworked. He went down to the States, where I walked into this hospital. It looked like it was a set from Grey's Anatomy. And I finally understood that that's actually what hospitals look like in the States. And he was able to just, through his benefits, he worked for United, be able to access healthcare right away. Right. So in that, being able to access that did save his life. But not everyone has access to that level of healthcare. Where I always make the joke that if Breaking Bad was set in Canada, it would have been 2 episodes long, because then he just would have started chemo the next day, and that would have been it. Because in Canada, that healthcare would have been covered.
Right.
In the States, he didn't have that healthcare. I've never actually watched the show, but I know the premise.
That's pretty accurate. I just watched it again recently, and that's true. The whole premise of it, I mean, I think there was a desire to become sort of somebody. I think there was an ego aspect, and perhaps that needed to have been satisfied regardless. Yeah. But, definitely there would not have been the same storyline, because you don't need to pull together hundreds of thousands of dollars for your treatment in Canada. And I wonder, too, if the issues around our public healthcare system are related to the fact that it's a public healthcare system, or the fact that we're not funding it well enough, or there's not good enough coverage, or something along those lines. So when you look at private versus public, I would compare 2 systems working properly, if that makes sense, right? Like, you could look at public healthcare in some countries of Europe and go, okay, well, that actually looks like a really good model that I would see helping everyone, possibly. Whereas if you're not funding it properly, you don't have enough nurses or enough doctors to take care of the people who are coming in and trying to access healthcare, then of course they're going to go to the US, because they need to survive at that point.
Yeah, well, I mean, chronically underfunding and leading to overuse of overtime, lack of prevention. So if a patient goes and they're having symptoms and they're told, oh, it's nothing serious, just go away, because the doctor's thinking about all the other patients they have to see and they're not going to investigate a little further, could turn into a much more serious health problem later on. I wonder how much we could save by properly funding and staffing our healthcare system. Yeah.
I mean, I've had a doctor for 2 years. My family doctor switched in the middle of COVID. So I have a new doctor who I've never even seen in person. I've had plenty of issues come up, and we've had, 5-minute chats on the phone. And but I don't know how useful that is necessarily, right? Like, is 5 minutes on the phone with the doctor where you're trying to adequately describe whatever it is that you're dealing with going to be enough for them to say, oh, yeah, you actually need XYZ treatment, right?
Yeah.
And what impact do you think the pharmaceutical industry has on healthcare? So when it comes to social justice issues, I often take issue with making huge profits on anything that should be a basic necessity of life.
Mm-hmm.
So we've, in our housing podcast, talked about landlords price gouging, for instance, right? And that's not something that I agree with, even as a landlord myself, because there shouldn't be those massive profits off of people just trying to get something that they need to live. So that would apply to food, but it would also apply to healthcare, right? So if you are privatizing healthcare and providing it at such a high price because you're trying to rake in as many profits as possible, I have an issue with that. And the pharmaceutical industry is pretty well known for doing things like that, or at least certain companies jacking up the price of medication that people need, because there's that whole supply and demand aspect of business, right? If you jack up the price, but that person needs it to save their life, well, they're going to pay it regardless because they don't have another option. So what impact do you think that has on the overall healthcare system?
This may be a little bit of a tangent, but I know that we've had this huge debate with anti-vaxxers. They don't like taking vaccines. The for-profit motive of pharmaceutical companies and the times where they've exaggerated the value of their medicines or the necessity of their medicines, that's feeding into people's distrust of medicines, and with good reason, because do I really need that medicine? I'm always thinking that, right? And I think that's where anti-vaxxers are coming from, and that's, I think it's fair. I never get so mad at anti-vaxxers, even though I'm in favor of vaccination. I think it probably saved a whole bunch of lives. I understand where they're coming from.
You think it's that distrust of big pharma that's causing people to not want to get vaccinated?
Yeah. And I mean, if you look at people in healthcare, maybe require different professions to have a certain amount of professional development, keep their skills up to date. Those are often funded by pharmaceutical companies to teach the healthcare professionals about their particular medicines. And so that's how I think that there's a little bit of if we could have our whole everything be not for profit, if the pharmaceutical industry could be not for profit, we'd have a whole different story in healthcare. We might be using way less medicine, and we might have other fantastic medicines that were delivered at a low cost, rather than sometimes the higher cost thing, which is a marginal better outcome or something, right?
Yeah. Yeah, it's hard to say because most medications, once you start taking one, there's a side effect that you eventually will have to take a medication for.
Right.
My prescriptions and everything have always been covered through myself being Indigenous. So I've never known the cost of certain medications. I never even knew about this MSP thing that everyone was paying in BC because I was told, oh, Canada has free healthcare. And because my MSP was covered, I never knew. And then someone mentioned that it's all this money and I was blown away. But I don't know how much certain medications cost. But what I do know is that when I was in nursing school, I was very anxious. My finances were low. It was a tough time. Nursing school is terrible. Any nurse will tell you that. It's an awful time. And I went to the doctor and they prescribed me with an SSRI, which was citalopram. And when you take that, there's side effects to it. And for a lot of people, there's quite a bit of weight gain, which then can add to other health problems. And there was no discussion, going back to the whole pushing of things versus the mental health aspect. There was no offering to me of other ways that I could combat my anxiety. And you find that a lot with other things too. They'll just give you a pill for your heart. They'll give you a pill for certain things. And I wonder how much is just doctors being told themselves, this is what being a doctor is, or if it's them pushing. I think in the States, certain doctors, and this is me speaking on, I'm just assuming here, certain doctors have contracts or something with certain medications, and I think that they do push certain medications over others.
Yeah, I've heard that. I think John Oliver might have done a story on that.
Yeah. I don't know if that's in Canada just because of the universal healthcare.
I'm not sure either.
Yeah.
I went to a psychiatrist in university too because I was having anxiety.
Yeah.
And it was on campus, and he said, I can't remember the name of the drug. Let's say it's lorazepam or something.
Yeah.
I'm a lorazepam, ma'am. I think everybody's got anxiety and because of this particular issue, and everybody needs lorazepam, so I give it to everybody.
Yeah.
It was almost, and he was dressed like a used car salesman. It looked like he was really just selling something, and I think he was almost being ironic, kind of telling me, this is the best you can do with a psychiatrist, right?
Mm-hmm. Yeah. Well, lorazepam is great, and if there was doctors like that now, people would be going to those doctors because, to my knowledge, it's very hard to get lorazepam. It's very addicting because it works. It really works. I take it for flights.
Interesting. I had a weird incident with psychiatrist because I was trying to find someone to help me with my mental health issues. I couldn't afford to pay for someone out of pocket, so I was trying to access someone through MSP, and I got turned on to this psychiatrist. Turns out he has horrible reviews, which, I mean, I didn't even bother looking at the time because it was literally the only person I could have access to. And they, within like half of a session, like 30 minutes, they diagnosed me as being bipolar, and then gave me medications for it, which they said had no side effects. Turns out they had very bad side effects. And then prescribed me medication to deal with the side effects, claiming that the side effects were not being caused by the medication, but some other mental health issue that I had. And then those two medications combined meant that I couldn't sleep. So then I got prescribed pills to sleep. And then when I finally came off of the medication, I was bedridden for 3 months because of all the side effects.
Yeah, it's a burnout and everything.
And it just seems like such a broken system when that's like that. I should never have had that experience with that person, but that's an experience that probably a ton of people are having.
Yeah, imagine how many, that's one doctor, and imagine how many people he accessed.
Exactly.
And the education around a lot of things to do with healthcare is not well known. Going back to vaccines, after the first dose of vaccines went out, I used to work for a brewery, and I did sort of a celebrity shift for them. They needed someone to work. And they were handing out, or they were giving away free beers or free drinks with your first vaccine to sort of just encourage people. And I, at the time, worked on the COVID ward, and every person that came in and had their little sticker, like I got vaccinated, I'd ask them questions about the vaccine. Which one did you get? How long do you have to wait until it's effective? What percentage are you effective? How does it work? What are the side effects? When can you get your second one? What's your percentage with the second one? They knew none of this information. And I feel like the government failed Canadians in not making that knowledge public. Or very easy to access, because for me, I sort of thought that everyone understood what I understood, but my career allows me to understand everything that I read. And I had like in real time access to all of this information. So new things came out. So I knew all about Moderna. I knew all about Pfizer. I knew all about, what was the one that started with A? The Johnson & Johnson, the one that no one wanted.
Yeah.
It's forgotten now. No one cares about
exactly,
it. But I had accessed all this information, and I also saw how the vaccines were affecting people in the hospital. Because I watched the shift between, regular good old COVID and how it started, and Delta, and the shift in that. And I used to ask people, when do you think the pandemic was the worst? And they'll always say, April 2020 or like May 2020, because that's when we cared the most. That's when everyone was inside and we were clapping for everybody and we were lining up. We were respecting the 6 feet. It was April of 2021.
Yeah.
That's when COVID, like the Delta variant, hit the hospitals. And I have always wondered if Omicron would have been as drastic as Delta if people had not been vaccinated.
Right.
So, but I really felt when it came to the education for you, being told you're bipolar, why wouldn't you trust this doctor, being given these medications, you didn't have like an informed consent when being given all these medications. You weren't explained what they would do, how they would work. Plus this doctor seems like he was a kook. But...
Yeah, he was explaining what they would do and the side effects, but he's going, very minor side effects. Yeah. Maybe you'd get a little headache, every once in a while.
Yeah. But like education when it comes to social justice is huge. Because when it comes to medication, a lot of people don't know that with a lot of heart medications, you can't have ginger, you can't have garlic, you can't have grapefruit. It's all these different things. If you're taking any antidepressants or certain antidepressants, you shouldn't do psychotropics, you shouldn't do mushrooms. But they don't tell you that. And young kids, they might be on something and then have a night out and eat a mushroom chocolate, and there can be negative effects to that. So we're not really educating our people on the medications they're taking and the vaccines they're getting.
Yeah, the education piece is really big. My parents are both sort of academics, so they do a lot of research. And the only reason that I wasn't surprised when you said April 2021 is because my parents had told me that. And I think also Justin McElroy was creating these, people might not get this reference in the podcast, but creating these charts where you could kind of break down how many people were being sent to the hospital, and then you could see how many people were vaccinated at any given time. And sure, it did look like it wasn't as bad in April 2021, but you could tell based on everyone being vaccinated and the spike still going up that it was
people were just starting to get vaccinated, double vaccinated, I should say. It felt like it was overnight. One day, I had never sent someone down to the ICU under the age of maybe 55, and they were immunocompromised, they had other comorbidities. And then one day in April, we had a 17-year-old sent her down to the ICU. We had a couple of men in their 30s get sent down. We had a lot of pregnant women. And I even had a moment, I don't know how true this was. One of the respiratory therapists had come up, and there's this machine you put people on. It's a high flow machine. And basically it just increases the amount of oxygen going into your body. And she looked at me and she said, "This is our last one." Wow. And it kind of like, we didn't say anything, but I was kind of like, okay, what happens after this? What's the next move? Right. What's the decision?
Because that happened early in the pandemic, right? With some of the areas in the U.S. where they're like, let's just let it rip. And then their hospitals got overwhelmed. Yeah. We didn't hear about that happening here.
No, and they weren't quite overwhelmed. I can only speak on the one health authority. I mean, everyone was overwhelmed. But we never had to go down to the measures of pulling someone in their 80s off because someone in their 30s needed the machine.
Oh, gotcha.
To my knowledge.
Right.
And that probably wouldn't be made public if it did happen. But I was working on that ward, so I never really felt like that happened. But the ICU was pretty full, and that all happened in April 2021, and the public didn't know.
No, the transparency has been awful.
And that could have been a huge campaign for vaccines. To be like, hey.
And wasn't that when maybe I'm wrong, but I remember there was this time where everybody was staying home, isolating, being careful. And then there was this idea, the pandemic's over. We can go out again. We can go to the pubs opened or whatever.
Yeah.
And it was clear if you looked past the celebration that there was still lots of COVID going around. Was that that same time?
I don't know. I feel like we opened and shut down Vancouver a lot. I know that we had all the plexiglass up that summer, but we sort of, after a couple months, kind of let everyone back in the summer of 2020. And I know that November is when Bonnie Henry shut everything down again because she did it very abruptly.
They opened everything back up for the election, I think.
Yeah.
And then they were kind of promoting, we've handled this really well, and then as soon as they got reelected, everything started shutting down again because the cases were starting to go back up.
Yeah, and they did it really quick because I, again, happened to be working at that same brewery. It's probably one of the 2 shifts that I worked, and I happened to be there. She called it, and there was a wedding that night in one of the banquet rooms, and we had to tell them at midnight, you guys have to go home because it was an at midnight rule.
Wow.
And so these people who the restaurant gave back some money or had probably did something to compensate these people, but it was that quick that was the second time we shut down, November, and then the third time would have been March. So right before when Delta hit, March 30th, I think, she shut it down really quick too.
Right.
Yeah. And then you saw the soar. Yeah. So I can't really remember because I really do feel like we opened and shut everything down so often, but yeah.
Ben, you work in the Health Sciences Association of BC. Can you explain a little bit about what that organization does and what your role is within that organization?
Yeah, it's a healthcare union for a number of primarily hospital workers. I don't work in a hospital. At my local, I'm a lead steward, so I'm doing sort of supporting the healthcare workers. I've also done some of the work of liaising with the provincial government to advocate for some of the needs of our workers in our union, which are pretty universal too. So, I mean, when I brought up respiratory therapists, they're in the Health Sciences Association. They're facing critical shortages in the hospitals and working, some hospitals, they're just, everybody's doing overtime all the time. Our unions also has a really strong social justice angle too. So we do a lot of support for social justice organizations. We lobby the provincial government on all kinds of issues for access, inclusion, and social justice. So it really feels good to be a part of a union like that.
Mm-hmm. So there is a lot of political advocacy involved in your work. And is that maybe what led you to run as a candidate in the election? Because you are running, I don't know if we've mentioned this already, but you're running as a candidate for Coquitlam City Council at the moment. And I'm curious to know, my original question, which is that sort of what led you to get involved, but also what cities can do to address the issue of healthcare?
Yeah, it's a good question. I think it's like stepping up to a leadership role, like as lead steward, was sort of a step on the way. Because I think I hit a point in my life where I said, I need to find a way to get in a leadership role. Because sometimes I think when you're being led by people and you're questioning their decisions, you can either sort of be opposed to them and not working with them. And, this could go back to mental health. You could just develop a mental health problem, or you could take action and say, it's time for me to step up and lead the show myself. And getting involved in union leadership is a good stepping stone. There are a lot of positions along the way. In my career, I'm maxed out unless I wanted to become a manager. And I'm not really into that sort of checking people's timesheets and stuff like that. So I think it was the way for me to step up into, you asked about cities. What can cities do for healthcare? I think cities got out of healthcare in BC. I was looking into the history of it probably 50 years ago. So the cities may still be involved in like public health a little bit, like have a health department and stuff like that. And social determinants of health. So providing healthy spaces for people to do recreation, making sure that their living space is good for their mental and physical health, access for people with disabilities so that the city's accessible. In terms of providing space for healthcare, all cities need to, healthcare is often done as a small business. So if you look at a doctor's office, that's actually a small business. And I feel like, at least the city I live in, Coquitlam, we've moved more towards large corporate business space is what we're building. And we're like, well, we don't have any doctors. Maybe they're having a hard time finding affordable office space. Maybe that's one way the city can help. So, and could the city provide purpose-built clinic space for health services? Yeah, absolutely.
And can cities help to create space for hospitals as well? Because Coquitlam seems like quite a large city to not have a hospital.
Yeah, I've heard that before. I don't know too much about that. I think cities do have land, but I think they would often want the health authority to be purchasing the land. But I mean, if it concerns the citizens, maybe that's part of the deal. I don't know. Coquitlam has provincial lands, but they're subject to a land claim at the Riverview site, which was a healthcare facility. It was a teaching hospital 60, 70 years ago. Big mental health facility, also a teaching hospital. And there are lots of people that want to make that back into a healthcare space. I think even the Coquitlam First Nation want to make that into a healthcare space. So,
yeah, and it's such a great location. I mean, for mental well-being, to be in that environment, it's a nice place to be.
Yeah.
And Joe, you are a nurse, and you've been working throughout the pandemic. So you've kind of answered this a little bit, but what have you noticed in terms of how your profession has been affected over the last few years?
So what's interesting is that I actually graduated nursing school into the pandemic.
Oh, wow.
Yeah,
I didn't realize it was that recent.
I'm considered a pandemic baby.
Huh.
So I actually don't have a basis of what being a nurse was like previous. And I actually went right into a COVID ward.
Wow.
Yeah, so I did my first year on the COVID ward. And like I said before, it sort of gave me this insight into what was going on that I thought was just everyone knew. That everyone knew and I knew, and I had this very unique insight into everything. But I have been told by other nurses of this golden era before the pandemic where things were a little bit better. I did mention that we are seeing a change, even from me being brought in right away. So this would have been July of 2020 versus the years now that have come where new grads are coming in. The difference in the education that they have access to because of the pandemic is impacting maybe if they're prepared for the role of being a nurse. A lot of the times students didn't have access to the hospitals, which is where you do all your clinical work. They didn't have access to, depending on how you learn, they didn't have access to in-class. I did my last semester online on Zoom. It was awful. I did not learn as much as I should have. I do study well by myself, but I felt like I was wasting 8 hours a day zoning out because I was just staring at a screen. And I missed that interaction.
Were there, were you having to miss out on some of the hands-on experience that you're meant to be getting?
No. So the structure of my school was the last semester is your research semester. And they did a good job structuring how that semester would go because you were supposed to have a community rotation, but that's a different experience. So I could have worked for Inside. I could have been a street nurse. I could have worked for the downtown Eastside neighborhood house. And so you're learning how to work with people in the community, and that's your last semester. So we missed out on that, but I did have access to the downtown Eastside neighborhood house, I think it was called, and I was in correspondence with them. I was still attached to them. And I actually learned a lot about the resources that Vancouver had. So I didn't miss out on that aspect. But other students that came after me, some of them missed out on in class. They missed out on some clinical stuff. And we're seeing that reflected in how prepared they are when they come to us.
Right.
Yeah.
So we're sort of in desperate need of nurses. And yet at the same time, the nurses that we are getting are not necessarily trained as well as they would hopefully be.
Yeah, it's just there's such a difference between learning on a fake dummy that has plastic skin versus seeing it firsthand. So I have noticed that, and that would be, it's a bit of an arrogant thing for me to say because I'm acting like I've had all this experience, but that's what I've noticed.
Have you heard that from other people in the hospital as well?
Yeah, yeah, and it's not the fault of the student. They paid the same amount of money that I did to get the education that they did, and they got the one that they got. And then it's sort of being left on the nurses that they work with now to sort of guide them into that, which then just leads to burnout with us. And we're already burnt out from the pandemic.
Right.
Yeah.
Burnt out from the pandemic in terms of like mentally burnt out or getting sick because of COVID?
Mentally burnt out, I would definitely say. And that more goes to just the way that they're funding the hospitals and the way that they're organizing the shifts. It's very hard to have adequate nurses. It's hard to have enough RTs. It's hard to have all these different things.
Mm-hmm.
And there needs to be a shifting of where money is going, in my opinion.
Mm-hmm.
So nursing is burning out. Nursing the profession has always been burning out. It's something you're taught in nursing school about nursing burnout.
Oh, okay.
Which is an interesting thing to teach in nursing school. It's like,
Right.
hey, this thing's going to happen to you. You're going to get burnt out at your job.
What did they blame that on?
So 20 years ago, you could have 4 patients and they would be in with one thing. So modern medicine is this amazing thing. We're keeping people alive longer, but now we're managing all of their symptoms. So before, with the older boomers, they're just starting to age into old age, and they have all of these health issues that they're managing. So now you have a patient who is in acute kidney failure. They have a couple of heart issues. They're a diabetic. They take a bunch of different mood stabilizers, maybe. Because they're diabetic, they have all these wounds because they're not taking their insulin properly or something like that. Maybe they drink, so they have a liver issue. They have all these different things. That's one patient.
Mm-hmm.
20 years ago, you could have 4 patients and your patient was in with diabetes,
right,
or in with this. And that was it.
Is that because we suddenly have more health issues that just people in general are dealing with? Or is that because in the past, someone who was dealing with that many different issues would have just died?
It's a little bit of both. So definitely people dealing with that many issues would have just died. Maybe not 20 years ago, but dialysis is very common now, where maybe years ago you wouldn't go on dialysis, and so you would either need a kidney transplant or you would eventually die of kidney failure, and it would affect you. And then also, it's just the way that, Vancouver is interesting because we're one of the more active cities, but it's the way that we take care of our bodies. And it does always go back to mental health. I've always said that the core of the issue with healthcare is we're feeding into the cycle. And if we got to the root problem, which is mental health, and we made mental health part of the universal healthcare, meaning access to counseling services, bringing mental health to the forefront, you would see a direct return, not only in healthcare, but actually in policing in probably 20 years, because a lot of the issues in healthcare are stemmed from self-soothing. So we soothe with food. We don't exercise. And if we encourage exercise, you would see, different things in the body. A lot of diabetes type 2 is brought on by food. Substance use. So people use drugs and alcohol to self-soothe, smoking, things like that. So if that was brought to the forefront, I wouldn't have as many patients in 30 years in with alcohol-induced liver failure, because they wouldn't be drinking to the point, to soothe themselves to the point that they are at that place.
Right. So it comes back to a saying, I guess, that I think I've used quite a bit on this podcast: an ounce of prevention is worth a pound of cure.
Yeah.
Make sure that people get that treatment earlier, and then you don't have to worry about treating, hopefully, quite as many issues in the future.
Yeah, and create humane conditions in society too, where people don't have to work 60 hours a week, 2 jobs, come home to a home that's very tiny and don't have any money left over,
Yeah.
Mm-hmm.
And that makes, I think there's a country, I don't know where it was, I read it and now I can't remember, where they're trialing the 4-day work week. Have either of you heard of this?
Finland or Denmark?
Yes. Yeah. And apparently the productivity is the same.
Yes. Yeah. And they weren't, a lot of places that have tried tests like this, or a lot of, I guess, theorizing around tests like this, is centered around taking a 40-hour work week and squishing it into 4 days. Mm-hmm. So 4 10-hour days. But I can't remember if it's Finland or Denmark either, but from what I recall, they were not doing that. They were basically saying, we're just going to take out a day. We're not going to add more hours to your other days. Yeah. We're just going to see if maybe you're more productive when you're not trying to just fill the time.
Yeah. And I think that in that circumstance, there's an incentive to be more productive, so you can keep your 3-day day off. weekend.
Yeah.
If I was given the option, like, hey, if you finish all your work in 4 days, you can get your 5th day off, I would get my work done in 4 days.
Well, I mean, that's what being an entrepreneur is all about, right? Like when I run my construction company, I get paid usually for the job.
Yeah.
This is the quote for how much this job's going to cost. So I'm incentivized to try to get it done quickly because the faster I do it, the more money I make. And the same could be true of any other job, but that's not how we really structure it.
Yeah. Definitely not nursing. There will never be, they won't be like, oh, if you can get more done in less time, it won't happen.
No.
Yeah.
I mean, there's so much to do, I guess, in nursing already that.
Yeah. You can't reduce our work week.
Right.
Yeah.
You need to add more nurses. And that.
You need to pay us more and add more supports for us. Yeah. Yeah.
So I'm going to go back to some questions for both of you just to kind of start wrapping things up. The first one is, if you could change one thing about healthcare in Canada, what would that be?
I mean, mine's to bring mental health to the top. And I've already explained why, but I think that is the issue. Mm-hmm. That is the issue, I think, globally to a lot of the physical ailments that we see. And if it became something that we acknowledged and worked on, that we would see that difference in, like, it would take us a few decades, but you would see that in the generations that come up.
Right, because so much stems from those mental health issues. Yeah. I guess it's kind of like in housing, where if you just put a roof over someone's head, you're not just solving the issue of homelessness, you're solving issues of crime and drug use and all sorts of aspects of what people resort to when they don't have a roof over their head. So it helps to address a much broader set of issues. Mm-hmm. What would you say, Ben?
It's a tough question. There's so many things that I would change. Mm-hmm. One thing I've always wanted to do was like remove barriers for healthcare workers to, for people to become healthcare workers and to do work on healthcare. Mm-hmm. We're always having professional barriers. We have to get great marks, spend a lot of money on training programs, and then we're finally allowed to make important decisions about people's health and well-being. But maybe we don't need that much qualification. Maybe we can, and this can happen in small ways. Like they're trying to make it so pharmacists can do more. Pharmacists can prescribe drugs is how or dispense drugs without a physician's prescription. And I think taking away those barriers would let us do more healthcare with people who are oftentimes really constricted in their role.
I guess there's an opportunity to, instead of having a nurse, for instance, who has to know quite a lot of information about a very broad range of things, you could have maybe more focused professions within healthcare so that the training is not quite as intense.
That might work, but the broadness in which a nurse understands their patient actually works to the advantage of the patient. If they're being consulted with cardiology and gastro and psych, those doctors really only specialize in those things, and it's the nurse that catches the things and brings it to the doctor's attention.
Yes, and I didn't mean that as like a replacement for nurses, but more so like how can we, to your point about trying to make healthcare more accessible, how can we find a way to fill the need for more healthcare workers in a way that also makes it, I guess, easier for people to become healthcare workers.
Yeah. I think that there's a lot of immigrants coming to Canada who are healthcare workers in their country, and we do not make it easy for them to match that.
We're not recognizing their
employment. Yeah. And then also there's a lot of LPNs, speaking from a nursing perspective, there's a lot of LPNs that work with me, and they should be given the option to challenge our licensing exam, which is called the NCLEX. And if they can pass it, they can become an RN, which helps the other RNs because there's a scope issue with LPNs and RNs. So they don't receive the degree because that's why you go to 4 years. That's when you would go on and get your master's from that. But you're able to practice as an RN instead of making our LPNs go back to school for 18 months and relearn all of these things that they're learning firsthand at the hospital.
It's a real barrier because to get the higher qualification, you have to come from a place of privilege originally, usually. But there are people who come from less privileged backgrounds. They start at a lower step, like LPN. But they're very competent, and you can, if there's a way for them to step up without having to put out the money for school, because you're almost caught in that strata of socioeconomic strata.
Yeah, and I think it's 2 years to upgrade from LPN to RN. And I often work with LPNs, and I have to write it on our board who is an LPN, because we're all so qualified that, and they understand the disease process and they have clinical reasoning, that I will forget who the LPN is until they ask me to do something that they can't, which is a very simple task. There are certain tasks it's not in their scope to do.
Oh, so they could do it, but they're not allowed to.
Yeah, it's basically, like, for example, hanging blood. They know the symptoms of a patient who is reacting to a bad transfusion, but on both ends, they're asking me to do it because it's not in their scope, even though they know how to do it. They could just do it, but they're not getting paid what I'm getting paid. So I would do the same thing if I was making less money. I'd be like, you do it. You monitor this patient. I'm not going to do it. They're paying me way less. The hospitals they have a great deal on the LPNs.
Interesting.
Yeah.
And what does LPN stand for?
Licensed Practical Nurse.
Okay, thank you. So my last question for both of you is, what advice would you give to someone who wants to advocate for better healthcare? This is how we kind of try to end all of our episodes.
I would say do your research, because what I've noticed in how it works now with media, on TikTok and YouTube, if people can poke holes in what you're saying, they will. And if you've done your research and you want to advocate for something, be prepared with the pushback, because people will push back. And I see a lot of people in person and on my little phone, and they're advocating a message that I am also passionate about, but they sort of say the wrong thing, and then people will run with that, and they can't back themselves up because they start tripping over their message.
Right. Yeah, I guess you can do a lot of damage in advocacy if you're not aware of what you're talking about. Yeah, there's a lot of amazing people who try to advocate, and they say the wrong thing, and we're all human, but then it just completely discredits them, and then it builds. Right. And then people don't trust that movement anymore. What do you think, Ben?
Those are really good thoughts. I mean, anytime we're talking about anything that's somewhat scientific, where there's apparently a right answer, there's so many ways you can just make that error, and then somebody who's clever at making a counter argument sounds right. It happens in climate change. It happens in housing policy discussions. It happens in healthcare. I was thinking of something different for advocacy. There's an advocacy group that I think has done great work in the province of British Columbia called BC Health Coalition, and they fought to preserve our public health care. That's what they're fighting to do, make sure that we still have a good, strong public healthcare system. So I would look them up. I think they're looking for support all the time. They can use volunteers or something along those lines? I think so. I haven't been heavily involved with them, but I know that they're looking for support. And I imagine, I think that they're an advocacy group. So joining an advocacy group is a good start, and I think they're a good one. And what was the name of the organization again? BC Health Coalition. BC Health Coalition. I hope I got that right. Fantastic. I think that's correct, yeah. Thank you so much to both of you for joining me today. It's been a really interesting conversation. It's always an interesting conversation on this podcast, but this is one of the topics that I feel like I know the least about, and I really appreciate both of you educating me. I'm Nicola Spurling. This has been a social justice podcast, and I'll see you again in 2 weeks. You've been listening to a social justice podcast hosted by Nicola Spurling, brought to you by The Flag Shop, and inspired by a social justice coloring book.